Okay, thank you very much. And my name is Philip Levinson. I'm on the advisory board. And before we begin, I want to introduce the second half of today's session here at the d.health Summit. But I want to actually ask you all a question, which is, how many of you here at the summit attended last year? Quick show of hands. Okay, that's pretty good. And how many of you are determined to make sure you attend next year? Raise your hand. Okay, that's good. I want to see all those hands up. I want to acknowledge the great work that Avi and Ray have done to pull this together. I think last year's event was great, and this year's is also doing extremely well. I think people are quite happy, and this afternoon's session is a good example of why. So what we're going to talk about this afternoon, there's some very interesting topics. I'm going to work backwards, and then I'm going to introduce the next panel. First of all, we're going to end our session today with a keynote address by Seth Schoenberg, who's the co-founder and CEO of Honor, and that's going to be exciting. Prior to that, we're going to have a panel on the changing insurance landscape featuring some great speakers and some great folks from the industry who are going to talk about that. At 3 o'clock, we're going to talk about investment opportunities in the aging in-place market. So that is going to be a particularly interesting discussion because, again, our focus is on aging and digital health. And then at 2 o'clock, we're going to have a keynote address by Clay Johnston, who's the Dean and VP of Medical Affairs at the Dell Medical School at the University of Texas. So that brings me to the very next panel. So I'm going to introduce the moderator, who also is from Silicon Valley, as am I. And if you haven't met Christina, she's an amazing journalist. She currently writes for Fast Company. Prior to Fast Company, she's written for VentureBeat, Reuters, and KQED. By the way, that's a very unique collection of organizations, very different. She also has recently published some great pieces on Apple, on Fitbit, and on the Cleveland Clinic, so I encourage you to check those out. So I'm going to introduce Christina Farr to you, and let's give a warm round of applause for Christina and the panel.
Well, thanks for coming, everyone. I think we're figuring out where we want to sit. It's like musical chairs. Oh, fine. There we go. Well, thanks. So we're going to be talking about the next generation health call today, and we've got a fantastic group of panelists, and I'm going to let them introduce themselves. I told them 10 seconds and no life stories, so we're going to keep it short and sweet. Thanks.
Yep, so I'll go first. My name is Ian Tong. I'm an internist by training. I'm a clinical assistant professor at Stanford, and I've taught in the medical school there for 10 years, and I'm the chief medical officer for Doctor on Demand. Doctor on Demand is a digital health solution that allows patients to access a physician from their mobile device or their home computer via live audio and video for a doctor visit. From the comfort of their own home, they'll reach a board-certified physician.
Great. Good afternoon, everyone. I'm Roy Schoenberg. I used to be a physician. At some point, I turned to the dark side of healthcare technology. And today, I run a company called American Well. We're also in the business of telehealth and telemedicine. We provide services to a wide array of organizations, including health insurance companies, as well as employers and a lot of health systems. And hopefully have a lot to talk about today. Interesting topic.
Hi, I'm a doctor, but in computer science, not in medicine. And also the founder of Pager, which is pretty much a platform to connect patients with high-quality healthcare. We do it. We combine telemedicine services with actually in-person visits. So we actually send a health practitioner to your home.
I'm the least qualified person on this panel. My name's Damian. I'm a washed-up investment banker. I'm the founder and CEO of TouchCare. We're a mobile platform that connects providers and healthcare teams to their own patients for a secure, video appointment. What makes us different is we're telemedicine as a social network. So you download TouchCare, you set up a profile, and then you invite your patients to connect to you, and you're live. So we're kind of all about providers and their own patients.
So this is kind of a funny topic for this panel, given that I had a next generation health call this weekend for the first time. So now I feel like I've had the experience as a patient. I used Heal, which is a competitor of you. I tried to use you, but you weren't available.
Or not. Yeah, we're New York-based. Yeah.
New York-based, yeah. And I had a doctor come to my home when I was sick, and we were deciding whether or not I should go to the ER or not. And I was able to actually avoid the ER, which was great. Awkwardly, this doctor knew my byline and told me he was a fan of my work while like pressing on my abdominals. Kind of awkward, but yeah. So I'm curious, just from having had this experience myself. Like, what are some of the reasons that people kind of decide to use these apps? Is it in a case like mine where they're wondering whether they should go to the ER? Is it for like more routine things like coughs and colds and or they need a prescription? Like, can you tell me about some of the reasons that you see patients flocking to
go
these?
down the line, kind of thing?
Or anyone who just feels most passionate can jump in.
Well, so TouchCare is all about providers and care teams and their own patients. So I would say most of what happens on TouchCare are things like chronic disease management, post-acute follow-up, sort of disease states where connecting providers with their own patients, where there's that continuity of care, there's the existing relationship. The provider can use their EHR. They don't have to change any of their workflow, except instead of the patient walking in, they just sort of pick up their iPhone and connect to them. So I would say most of our stuff happens there. We do have primary care physicians using it for sort of lower acuity things, but I would say that most of what TouchCare is doing is sort of the bigger disease states. But I think there are lots of different situations, and maybe as we go down the row, sort of it'll probably change a little bit.
Yeah, for us it's urgent care mainly, and there's two buckets. I would say that they use it for convenience and comfort. Also logistics. Let's say single parent, you have two kids, one is sick. You want a doctor to come to your house. You don't want to do all this hell of taking all the kids and taking a car and going to the doctor. So this is one thing. The other bucket is people that they don't know what to do. That's the reality. So you go to WebMD and you find out that you might have cancer. You get scared. Then you come back to a pager. And then you can talk to a doctor in real time, and then the doctor can assess if you need if to go to the ER or you can be treated. So it's a lack of knowledge, and the other thing is convenient and comfort. This is what we're seeing, from our data.
So we are going down the line. Okay. So so there's really three domains that we operate telemedicine and telehealth in, and one is, as was mentioned, the urgent care piece, where I think many of you are familiar. The one that you used. In a sense where a patient initiates a transaction. They usually use their phone or browser or, an app. They see whichever physician is available, connect with them, and it's a very kind of a blind date exercise, right? So the nature of the transaction is very primary care. Usually some people would kind of cynically call it, it's the way to get to a Z-Pack. It's the quickest way to get to an antibiotic. Then there is the part where telehealth is being used between physicians and their own patients, a little bit like what Damian was saying, the primary care physician that uses it with their patient to follow up for, with conditions like diabetes and asthma and CHF and so on. This is the longitudinal relationship that can be fueled by telehealth in a big way, especially when patients are elderly, when they have conditions that make it difficult for them to follow up and be compliant with medical regimen. And then the third area, which frankly is booming beyond belief, is the area where health systems, hospitals all around the country are now becoming more involved in how well their patients are doing after they leave the hospital, usually after surgery or when they do chemotherapy for cancer and so on. A lot of reasons why that's the case, mostly financial reasons that have changed how physicians are being paid for. But the reality is that now that they understand that they need to know what's going on with the patients that we've just discharged, they're buying telehealth capabilities to envelope their patients at home, to be kind of check up on them for a couple of minutes or twice a week or 3 times a week. And that's where you see post-surgery, that's where you see, cancer patients, you see the very, very high end of the acuity of healthcare happen. So it's the entire gamut at this point.
So I'll just say yes, yes, and yes, and then add that all of this, everything that these guys are saying has happened in a context where people are becoming more connected. We all know that we already are also in the context of a fairly broken healthcare system. So who's coming to us are people who either come from the most informed consumer or the convenient person who's just scared and worried about their medical condition. And they look at their app and they say, well, there must be an app for that at this point. And then they find that there is an app. There's a way for them to very quickly, easily access high quality medical care. So I think that's the context in which this is happening, and our various practices are developing, and I think morphing as well, because the problems and the kind of problems we're seeing are evolving over time, actually. So we were much more like an urgent care, but what I'm seeing is repeat patients coming to us. They actually want to use us for more things, more complex medical problems, a broader spectrum of medical problems. So we started as an urgent care as well, and now we have psychology. We also have a psychiatry service. The patients are, I think, telling us that they want more things through this model, through these platforms, to improve their access.
And what are you finding that patients are really looking for from these experiences? Do they just want to walk away with a prescription, and that's kind of how they know that they've had a good experience, or do they want kind of medical advice or medical information? What do patients kind of, from the surveys and the research that you've done, what are you finding that patients want?
Yeah, I think maybe I'll just start with that one. Is that there is no doubt a percentage of patients who do think this is just an easier, more convenient way to get what they want. They've self-diagnosed. They're practicing medicine. I like to joke about it. Practicing medicine without a license. They've already know what they have, and they just need me to kind of write my name on the line and provide them with what they already know that they need. But when we've actually looked at the research, it actually and there's research out there in a JAMA article from last year in April, written by Lori Usker-Pine, showing that antibiotic prescription rates are actually about the same as brick and mortar practice. Now, that's not the goal, because brick and mortar practice is extremely is abysmal at antibiotic overprescribing as well. So our goal is certainly to outperform and beat brick and mortar practice in that area. When we look at our data in our antibiotic stewardship program, it actually looks like we can beat national averages for prescribing, but patients actually rate us the same whether we prescribe or not. So we're just as likely to get a 4 or a 5-star rating whether we actually provide the antibiotic or not. For sore throat, bronchitis, or sinusitis. So I think what that means is I think patients are coming to us for access to healthcare. And when you provide that for them, a visit, a history, a physical examination that's virtual based, it's going to be on a 2-dimensional screen, but when you give them all the parts in the ritual of healthcare, they actually walk away feeling like, I got healthcare, and that's what I wanted.
The problem, so let's mix the line up so we don't always follow.
Yeah, we don't have to answer every question.
Consumers want, convenience, quality, value, right? I mean, just whatever you're buying, car, lung surgery, new house. I mean, the theme's always pretty consistent. The question is how do you access it in a convenient way? The problem I think that we face right now, and there's lots of problems we talk about telemedicine, is it's good if you want low acuity urgent care. That's pretty readily accessible. Get on Doctor on Demand right now. Get on American Well right now. You can do it. The real issue is, as a consumer, when you get to the serious stuff, you get really siloed. Because here's what happened. You walk into a health system, you're like, I'm really sick, I want to go to Duke. I live in North Carolina, so pick Duke. They're like, well, we're on Epic, so you need to go to our My Charts portal. You're like, oh, great, another log into a website I don't need in my life. So you log in there, but then your primary care doc's like, no, I'm on Athena. Like, okay, I'm on Athena. And then your pediatrician's like, wait, we're on eClinicalWorks. You're like, no problem. Let me just rack up 7 different patient portal logins. And so I think that the way that the consumer accesses the network of care that they choose to affiliate with is ridiculously complex. And what healthcare's not grabbing onto right now is the mobile consumer is trained to do everything on this device. We're all trained. There's no teaching required. We just need to put services onto it.
Yeah, and I would add instant gratification, right? So the fact that, you click a button and you get food. You click a button, you get a car. You want to click a button and get healthcare. This is new generation. This is what people are getting used to, living in these countries. So from our experiences, they want answers. They want answers to a problem, and also they want to feel that there's somebody outside that cares about their healthcare. So there's a psychological kind of human psychological factor that plays an important role on our service. And people just come back. They keep coming back because they found that. Most of the people, what they say is that it's easier to get a service from pager than actually an appointment from their primary care doctor, which is sad, but it's true.
Yeah,
I would just add to this that I think expectation management is a huge challenge for telehealth right now, because it's really unclear to a lot of people when they click the button what is it that's on the other end. And one of the challenges is that a lot of the telehealth solutions that are out there actually have positioned themselves, sometimes because it's just faster and less expensive to do, they position themselves as an alternative to the healthcare system. You download the app and you're going to see some physicians who are associated with the software company, and they're going to deliver care to you, and it's going to be completely outside of anything else that has to do with your healthcare. Whereas I think more newer generation of telehealth solutions that are coming in view telehealth very differently. They're looking at telehealth as an extension of the traditional healthcare system further closer to where the patient is, which, if you think about it, is a remarkably different kind of heavy lifting, because if you want to really expose, we talked about Cleveland Clinic, for example, so we work with them. If you want to expose Cleveland Clinic services to patients, you have to blend into Cleveland Clinic physicians' daily lives. You have to blend into how they do medical records. You have to deal with their schedules. You have to deal with how they collaborate. You have to understand who's going to pay for it. You have to understand things that people don't want to think about, like continuity of care and those kind of things. But the truth is, the power of telehealth is so unbelievably larger, unbelievably bigger, if it is the use of technology to deliver the healthcare that we already like, the healthcare that we already trust, the brands that we know, the physicians that we have relationships with. This is the part that where telehealth will deliver, at least in our mind, the biggest, what's called ROI, but it's a heavier lifting than the quick to get a media coverage article about, it was a stormy night in North Dakota in February, and a mother of 3 had a bronchitis and found the physician on the phone and got a prescription for Z-Pak. That gets published very often.
Thanks for not quoting one of my stories.
We'd have to read them first, Christina.
Like your doctor, we really appreciate the stories that you write. But no, I think the reality is that this is the biggest challenge now of telehealth, to somehow escape from the notion that telehealth is all about convenient care, accessing a physician through a blind date to get a Z-Pak, to the understanding that telehealth is really an extension of healthcare through technology into where we all are. And in the end, the healthcare system is there to serve us all. So
maybe quick on that. So, quick show of hands: who this calendar year, has done a video appointment or video call with a physician on their iPhone or a mobile device? Hands up. That's terrifyingly low, right?
they're all healthy.
Okay. Who's done one?
That's growth potential. Growth potential.
Or in the last 12 months, who's done one in the last 12 months with their own provider or a provider that provides care to them on an ongoing basis? One. That's even surprising to me. But that's the point. Normally you get 10 hands go up saying they've done a video call, and then 0 hands have done one with a provider that sort of knows them, etc., etc.
Yeah.
What about just texting or messaging a doctor? How many have done that? Okay, so
because we're in New York,
this
high-end
is going to
doctors.
feed
We're getting
into a
there.
later question about video versus text, and less high touch means. But I really do want to press on your point, because I'm talking about my own experience a lot, but it's just kind of top of mind. I tried to integrate with my insurance company, and it just kept not working. So I called up the customer service line, and I was like, how come you can't check if United will cover this? And they're like, oh, United Health Service tend to go down on weekends. Yeah,
no one trusts their insurance
and then
company.
I got a medical record sent to me just from this one visit, but of course it doesn't integrate with my existing medical records. There's nothing really I can do with it. So you could see that they were sort of making an attempt to engage with the healthcare system, but it was sort of quite tentative, and at times just didn't work. So I'd love to kind of press more on your point of whether we should even be trying, and when we do, are we just going to create more pain points for patients?
So I would a quick answer to it's. There's a sweet and sour story here, right? I mean, the challenge is that, of course, when you try to integrate those things into the way health plans work, and in some cases into EMRs, these systems were really never built to live in the day and age of immediate service, of immediate transfer of information, and so on. That's the bad part, and it's very challenging. And by the way, I can tell you that, and the people that are here on the stage know this very well, integrating with those is very required. That's the part that is extremely expensive. That's why organizations that are going into telehealth that want to do the right thing need funding in the hundreds of millions of dollars in order to create this new way of care delivery. It's not an easy thing to do. The good news, however, is that, and that's something new literally in the last year or two, that the people that run those giant organizations have actually stood up on stage and said, yes, we will connect our system. This is going to be part of our future. This is going to be part of healthcare delivery, both for urgent care as well as for follow-up care. And if we are a large health insurance company that's going to do it quicker than the other guy, then we will prevail in the market. So the messages, the music is now going the right way. Changing the systems usually takes another year or two.
I have some comments on that just from painful experience, having been building a company for 2 years. We tried really hard to integrate with a bunch of different EHRs. And actually what we learned in practice is if you let the providers, the physicians, just live in their EHR and not change their workflow at all, telemedicine works really well. So at TouchCare, we actually say to providers, schedule in your EHR, chart in your EHR, run your scripts through your EHR, do everything in your EHR, whatever it might be. Just use TouchCare on the side as the way to do your video appointment and build your network of patients. And the lack of integration has made it grow really fast. So it's not the perfect answer for down the road because we're not talking about interoperability of data. But if you don't change the provider's workflow, you actually can fit in their day because then it just becomes, do you want this appointment on video or do you want to come in? I mean, it can be that simple. You really don't have to overcomplicate it. And we learned that by painful trial and error.
So I was talking to some colleagues at Fast Company who don't cover healthcare yesterday about this panel. And I told them we were going to be talking about telemedicine. And the response that I got back from like 3 people immediately was, why would doctors agree to do this? Which is probably one you get all the time. And I think it's a really fair point. Why would an overburdened doctor, especially like a top specialist who's already, got like a long waiting list, why would they bother with telemedicine, especially if it just adds more hours to their day?
There's a slew of cynical answers to that question. Well, money. The reimbursement is there. I mean, the rules are growingly around the country that physicians are going to be reimbursed, are going to be paid, in most cases, the exact amount of money for seeing patients through telehealth as they do through in-person care in their office. The difference is that patient satisfaction is higher. The difference is that physicians can actually get a little bit of a life back because they can do it from home and they can do it after hours. And the truth is that a lot of the changes in which they're paid now require them to be available to their patients after hours, and in other cases so that the patient don't go to the emergency rooms, which are proliferating them in urgent care. So interestingly enough, and I think this is your experience too, there's an endless flow of physicians that want to do this. I don't want to use terms like shooting fish in a barrel, whatever it is, and respectful to everybody.
Yeah, we won't use that.
The reality is that there's a lot of physicians that want to do it.
It's not just physicians, though, right? I mean, we have a lot of mid-levels, a lot of support staff on
Yeah.
TouchCare. It's engagement between care teams and patients. Yeah. It's not always the physician. In fact, it massively increases the efficiency if mid-levels or support staff are doing patient follow-up, especially in a value environment. Think about ACOs and a move to value, right? I mean, you're a doc, so you should probably answer that question, but we see a lot more support staff and mid-levels than providers, actually.
Yeah, what we see in Pager is that you can use telemedicine for 2 things. Mainly follow-ups, after the visit. 24 hours later, they engage in the conferences, which is easier, to talk to somebody and look at the face to evaluate, how the patient is doing. The other thing is that what we do, we don't only dispatch doctors. The first thing we do, when you have in Pager, you talk to a ER trained nurse. She assesses, the acuity of the problem, and then she can decide whether, the best venue of care for you is telemedicine service or sending a provider. A provider could be a PA, could be an NP, and then, we send the NP, to your house. And then once the NP is there, we actually loop a doctor in via telemedicine. So he's actually supervising, the NP while doing, the visit. So this is how we're making, the supply chain more efficient, just to, to give it the logistic chain more efficient. We can actually leverage technology. So there's always a doctor supervising the whole process. So it's not only for a visit, it's not only for a consultation. You can use telemedicine services for different pieces, in this puzzle.
I agree. Oh, you want to go?
No, just one 30 seconds exercise. What you just did. So. Anybody here that had either text messaged, email, or talked to the doctor on the phone in the last year, if you can raise your hand? Okay. The reason why doctors do it is because for all of that, they don't get paid.
Yeah. That's a good point.
Well,
that's a good point.
That's it. And if they did it through telehealth, they would get paid.
And I think that is very true. And so there's a number of, I think, cynical reasons, and we may jump for those, because of how we might be feeling on a given day. But there's also, less cynical reasons to do it because I think all physicians are aware, and everyone in this room is aware that there's not just a national, but there's a global healthcare shortage. We know that. Now, maybe not every doctor is going to make their decision just based on what's good for the, for the globe, but some do actually think about that, and some actually do think like that. If you think back to what those core values are that physicians have, to decide, well, I can go into iBanking, and I could go be an attorney, or maybe a reporter. I wasn't smart enough to do that. I have an English major, though, by the way.
You're not going to get paid for that.
Exactly. I was an English major. Didn't, maybe not so useful. But no, I think you have multiple options, and so when you do the work the kind of work that I've done at the VA, for instance, I was the medical director of Veterans Outreach. The program that I started was doing outreach to homeless veterans. We had a mobile clinic. We were going out. I'm seeing patients under, on freeway underpasses, in places where healthcare is normally not going to be found for veterans who very badly need care. That's how I began the first 8 years of my career, building a program like that. And I see leverage, and that's not scalable, though, right? That's actually not going to be scalable to solve the healthcare crisis that we're all going to be facing now, and is only going to actually get worse by most projections. So I think doctors do understand some of that global demand, want to be part of the solution. And then, yes, there's a ton of frustration not being able to leverage your expertise and your experience across a vast area or more patients, or you're filling out forms. I mean, every doctor can tell you the story about how frustrated they get because of having to navigate in the system that exists. So I think there's a lot of thirst for a better, more efficient way to serve that that broader mission.
So I think we got to answer that question in the context of value, though, right? Because I know everyone in this room is probably fee for service, but there is this whole move to value going on, supposedly, right? So there is a mindset towards value. I'll plug one of our partners, d.health in Philadelphia, 400 providers, primary care providers, I think at shared risk for 100,000 lives. That's a real value environment. If they can put a portion of the care onto telemedicine, which they've done very successfully, for follow-ups, continuity of care, they've found massive reduced costs. They've also found huge patient satisfaction and great continuity of care. So that's a cost savings as opposed to making additional money, and it sort of works for everyone. So I think you think of surgeons in bundled rates, right? You can't, if you see someone with 30 days after surgery, you can't reimburse for that visit anyway. So there are bundled rate environments where it makes sense. I think there's a lot of sort of construct within value where it makes sense.
Yeah.
And I'm curious about, especially in your case and maybe a few others, like, when doctors want to work with you, like, what do you do from, do you employ them? Do you have them, like, contract with you? I mean, what are some of the models that have worked and not worked? And I think this is a really interesting question given the kind of Uber and Lyft whole, like, litigious
I'm the only one who doesn't provide doctors, I think, right?
Yeah, so the truth is that, there's different types of applications. We have, in many cases, because we serve very large health insurance companies, and they want to make sure that when they offer telehealth services, there's always going to be someone at 3 o'clock in the morning in Kentucky if a patient walks in. We actually do work with a large national group of physicians that is built and purposely operating telehealth services. These are physicians who have been credentialed by those Blue Cross Blue Shield plans or United plans. And what they do is they make sure that there is a basic level of service. So the lights are always on whenever you go into the system. On top of that group, there are physicians who are, who we actually associate with, and they come in when there is peaks and valleys of supply and demand, because we want to make sure that, everybody is going to get treated within a matter of minutes. But I think the part that is most exciting, and that's a new part that really just showed up in the last year, is the discretionary availability of physicians who literally download the provider app. They still need to get credentialed and tested and licensed and everything else. But these are physicians who are coming from the health systems who we work with, the large hospital systems, who have signed up to telehealth. And one of the beauties of telehealth is that they can use the same platform to follow up with their own patients, but when they're not in front of a patient, they can literally kind of flip the switch and allow traffic to come in and see them when they have availability, when they're not in front of someone. So we have a lot more of organic supply coming from, the 800, 900,000 physicians in America on telehealth networks.
And there may be some difference in between, some difference to the answer in that question from the physician services versus if you have non-physician services. But it's probably just worth it for this group to know, if you have less familiarity with our practices. you can employ. So Dr. On Demand actually employs a network of physicians. They're W-2 employees. We can have quality control programs. So I mentioned the antibiotic stewardship program. I can have that program and successfully get all 100% of my doctors to do 6 hours of continuing medical education in antibiotic stewardship because they work for us, and I have control of a certain amount of their time and
what
interest.
about the medical licenses, other state medical licenses?
So that's there's a lot of complexity to that, but that's the way that you actually have what we call them super docs, doctors who have multi-state licensure, so they can cover a wider area of the United States at a given time. So when they're on, that doctor is, it's a really good load balancing technique. That doctor might be busy in Kentucky, but it's very costly to have that doctor sitting around in Kentucky doing nothing. Now, and so hopefully this makes intuitive sense to you. When you have that doctor, though, who has 19, I'm just making up a number, 19 licenses, or maybe it's more like 10, but you'll have a doctor who has a number of licenses, and therefore they're not as dependent on that one state for the load balancing or keeping them busy and making them efficient. So that's one of the values of the service. But just think about that from our traditional healthcare model, which is the doctor sits in a place where they can be accessed, and then we try to funnel patients in at the right pace so the doctor can see them. And I think that because that model hopefully inherently or intuitively for you, you realize it doesn't work. You realize why services like this are needed, because we can actually better load balance the expertise and the experience of a very skilled workforce across a larger geographic area. So it ends up being a much more scalable answer to our shortage crisis.
Well, what we do is really simple. We say to the doctor, pull out your mobile device, download TouchCare from the App Store, set up a profile, and you're live. And you can now invite your patients to join your TouchCare network, or you can invite your colleagues to join your TouchCare network, and you've got an enterprise-grade telemedicine system live, and you're good to go. If you want to offer on-demand appointments to your patients, you can enable a little button so that on your profile you can offer your patients on demand, so they can click request appointment, fill out a bunch of triage stuff, and it'll route into you, and you can assign that to whoever you want. It could be the doctor on call for your practice, whatever. So it doesn't matter if you're a 1,000-provider health system or 2 docs in a small practice. You get set up on TouchCare the same way, and it's pretty instantaneous, and it works with your EHR. So that's kind of what we do. We don't employ doctors.
So let's talk about the next generation aspect of this panel. What does it mean to be next generation? Is that just like slightly better than what we have, or are we talking
high
like
valuation?
we're talking like, or the sort of the high, very high tech stuff like the video. And what have you found when you've done kind of research around the types of technologies that patients want to use to communicate with doctors? The number of hands, I think it was like 3 that were raised for video chats. That doesn't surprise me at all. And I can see a lot of kind of like awkwardness around a patient doing that. So I'd just love to talk about your experiences with like what makes this next generation and what kind of technology do you want to introduce into this equation?
Well, so to me, next generation is just like trying to do something that hasn't been done before. And so, I mean, it's a pretty simple thing we're trying to do. No one in this room has done a video appointment with their own doctor this year, so we're trying to do that. The technology, I don't think, is particularly complicated, actually, right? I mean, you can pretty much assemble. That's not true of Roy's business at all, or Ian's business. Of ours, a sophisticated technologist can assemble together the Lego bricks in pretty organized format. What I think makes it work is it's got to be designed thoughtfully around the use case of the user. It's got to be super easy to implement. And the next generation piece to me is it works for the mobile consumer. Like the world is mobile. The consumer, be it the provider, the nurse, the mid-level, or the patient, we all think like mobile consumers, so it's got to be in tune with that. So I would say don't go build some enterprise software suite that requires hundreds of thousands of dollars and consultants and implementation. Build something that looks like Dropbox. Right? I mean, that to me is the difference. It's like, do you want to be Dropbox and Box, or do you want to be racks of Microsoft Exchange servers? I'm just using an example, right? I mean, that's the way to think about the world, I think, right?
I would say that the term next generation is actually pretty terrible, because if you're a next generation, that means you're not in this generation, which means you're not, nobody cares, right? You're not delivering any value. I think in our world, yes, we do bring in a lot of new technologies, biometrics, diagnostics. We connect with a lot of different new systems. Some of them are incredibly exciting in terms of things that you can do at home in healthcare. But the part that I would say that is kind of the frontier for us is not so much the integration with the new devices that have a life of their own, but rather creating capabilities to integrate into the old healthcare, into the reality of the physicians that are out there and the nurse practitioners and the others, and trying to find a way to leverage their expertise through the technology into the hands of patients. And that is not so glitzy as, you know, the electrons on a system with LED lights that blink in the dark, but it's really more about the depth of understanding of what their reality looks like. And the reality, and that's things that people really don't want to hear about, is not only about seeing the patient and seeing data that's coming from different systems or different devices. It's about how do we deal with the eligibility for services? How do we collect co-pays? How do we submit claims? How do we know what product this patient is on? How do we know what other providers can participate in helping this patient? How do we know what medications they've been prescribed? How do we know what worked and what didn't work? All of those kind of things are critical components of the recipe that allows a physician to do good for their patients. The next generation of telehealth is one that gracefully brings those in. And that has a lot to do not only with devices, but also with, you know, literally understanding the biology and the behavioral thinking of the healthcare system.
Do you think that the patient, you know, the next generation patient is going to be using or communicating with their doctor like in person most of the time, or will it be video, phone, message? What will be the kind of medium?
I think it will be a blend. I think the reality is, you know, today, forget telehealth for a second. Today, we all acquire healthcare in a variety of different ways. We have things that we expect to go to our PCP, and they should be able to take care of us. But I'm pretty sure that if the PCP says, you know, you look like you have a coronary artery disease, why don't you lie down? I'm going to do a coronary artery bypass on you. That wouldn't go well. We accept the fact that there are different places of service that are right for different things in healthcare. Yeah. We expect surgeries to be done in large hospitals. We expect some things to be done at the outpatient clinic, and some things are going to be done at the primary care office. Telehealth is going to become the first line of defense. It's going to be the furthest reach of healthcare into where you are. And it will do more. I mean, there are devices, amazing devices like Taito devices that do self-examination coming into the market. But the reality is that it is going to be one care setting that's going to be using technology. And people will intuitively, I don't know if you've had an experience where a patient had a car accident and called doctor on demand, right? Yeah. From the road. That doesn't happen very often, right? People have some common sense. The reality is that we will just internalize the notion that we can reach healthcare through technology, and it will tell us what to do next. Sometimes it will care for us, and sometimes it will just guide us as to where we need to go. And in a world where everybody has now high deductibles, where the decision on where you're going to go is going to cost you money, that's going to be a godsend.
Yeah, we had a saying at the VA was right care, right place, right time. They don't always come with great slogans, but that one has stuck with me because it's actually what I think patients want. You know, I think they want the right level, whether it's a text message or to be able to see someone from a video, or to have that doctor in their home or that provider in their home at the right time. I think you want to have options. That's what I see. That's what I think that people are saying, and they have individual lives. For instance, we don't have this yet, but this is something I think that'll kind of weave back in with the conversations from earlier this morning. You have a parent, I've actually been through this, a parent who's not thriving, and I live in a different city, and I can't be there to see that are there groceries in the refrigerator, and is the place clean, and and is there a fall hazard somewhere in the that's still there and needs to be moved. And if you have a care provider in the home, and I'm remote, as either the concerns. I came here, by the way, as a panel participant. I'm going to leave as the concerned son, given what we talked about this morning, who has a mother who's facing some of these issues. I think that eventually, we all have very specific needs, and eventually technology will actually reduce the pain points of those needs. So, for instance, the scenario that I just went through, where I live in the Bay Area, my mother lives in Central California. Through a video platform, we could be in the same place at the same time through video. We could have a group visit. Doctor on Demand currently does groups of 2, but there's no reason why we couldn't build. It just, you need more reasons, and you need a business case for it. But I've been thinking about this for a long time. If you can do a group of 3, that would be very valuable to the concerned, adult child, or the patient and a subspecialist with the primary care physician, so the neurologists who are talking, and be able to bring the neurologist in. You were saying bringing that neurologist in so the family practitioner has the correct backup. Maybe we can reduce hip fracture or improve diagnosis of Parkinson's. So anyway, I see there's lots of leverage here. We're just on the front end. But yeah, I do think telemedicine will be a new front door to healthcare.
This is reminding me of one of the common kind of justifications I hear for why we need telemedicine is patients in really rural areas who don't have easy access to a doctor, which totally makes sense to me. But at the same time, I think about my own father and who calls me every 2 weeks to ask me about some issue with Windows 10, and the idea of him doing a video chat is just totally, he wouldn't even know how to start that. There are a lot of people like that who just especially in the older generations they didn't grow up with this technology. It's not native to them. Or just in these rural areas that just totally lack clear internet access at the home. So how are we going to kind of reach these patients with telemedicine? And you could argue that these are the ones who would need it most.
But we have to put on ourselves the same kind of requirements as other consumer products are. And I'm not working for Apple in any way, but when you buy this is a supercomputer per 10 years ago or even less than that. Yeah. Did you ever notice that there is no manual in the box? You buy a microwave, there's a manual. You buy a supercomputer that does 50 million things, there's no manual. And the reason is because they signed up to the notion that everything has to be completely intuitive. Yeah. And this is the way of the land. This is what Darwinistically will divide between people who do good and bad. Healthcare can be a consumer delighting experience. It doesn't need to be something that you try to figure out and ask 5 people to help you in customer support. It needs to be something that is entirely intuitive. And the reality is that, if Mrs. Jones, the 82-year-old diabetic, needs to follow up with her physician, it needs to be as simple as something pops up on her phone and she says, okay, it's time. She clicks and the physician shows up. Mm-hmm. And this is where we not only need to be, this is where we can be, and in some cases this is where we are. So it will become ubiquitous before you know it.
I couldn't agree more with that. I think so much of this is about, first of all, we have a lot of sort of the users on the patient end. They're in that sort of 60-plus range. Good, strong utilization. You'd be surprised by, I think it was 25% of folks over 65 have a mobile device, and if you take 65 to 85, it's higher, 40 or something. But the utilization's high because they FaceTime the grandkids. They are more used to the medium than you might imagine. And if you make it intuitive and beautiful and simple and one click, you can and
also there's a spillover effect, right? So you cannot pretend that there's certain demographics that will be the early adopters of these services, and then after they see the value, other demographics they're just gonna jump into the equation. So it is very naive to just think about we're gonna release this product and it's gonna serve all demographics around. So rural areas are gonna get there, but I think urban cities and young populations are going to be the early adopters of these services, and then they're going to expand. So.
Yeah, and I think it's just multiple people have their reasons. The rural, that's how I was introduced to telemedicine, was a rural program that we had. Our outreach program went into rural areas. We wrote a grant and attempted to use telemedicine because it's much more, it's longer distance for my mobile clinic to travel once I start doing outreach to rural veterans. But also, I think you don't want to miss, that we're in this current setting in the urban dwellings where you have people who are working 9 to 5 jobs and then also have a second job on the weekends and then actually have absolutely no access to care. So they do need they need more access without a doubt. So they may be just as isolated. So I think it's not just rural, but that is the beginning of telemedicine was answering the rural care shortage question.
Okay, so we're going to jump to questions in a minute, but I'm going to ask you guys one more question, and you've got to give me a phrase as a response, no more, or a word. That would be ideal. Biggest challenge facing telemedicine today? A phrase or a word?
Behavior change. I took that one early, so he's going to.
Reimbursement.
Adoption.
Regulation.
Wonderful. So these are all great ideas here for questions. If anyone has one, we've got about 10-15 minutes.
So you're the blood pressure assay seeing our patients on a continuity basis.
And Roy, American Well does as well.
Do that.
Do you want the microphone?
What's your sense of how many visits a chronic person can take in a row over the telemedicine versus having a personal visit? Is there a sense you have of that?
So I would say, and we have providers who can give you much better answers, right? But we've seen some, what I would call super users of TouchCare who it's just part of their day, do about 20% of visits in that sort of format. So it is supplemental to in-person care. It is supplemental to routine care. We've done everything from delivering Galaxies tablets to homes with care teams, walking the patient through how to use them. These are like morbidly obese, chronic disease patients who can't leave the home. And we've found that by doing 2 visits a month, you're now no longer sending the ambulance, the nurse, the wheelchair, the oxygen tank. I mean, it's like serious savings. But I think it's around 20 is probably in the chronic disease setting. But I could check and get back to you. I'd ask some of the ACOs we work with.
So, if I should answer a little differently, what we see is that the average visit is 8 minutes. So in terms of your ability, in terms of looking at how you utilize the hour, we do see primary care physicians putting in 6 to 8 visits within an hour, which, if you look at the reimbursement rate, actually ends up being more lucrative than what they do in the office. The other thing that I would say is that we see a lot of primary care physicians using the system to kind of divide the way they treat patients. They use telehealth to follow up with their patients on very simple things that are relatively lower paying CPT codes, medication management and those kind of things. That allows them to open up office hours to do the visits for higher paying CPT codes. So it's not the same kind of mixture, but they use it pretty well to change.
I agree with that, Roy. What I find is that providers come up with ways of using it you just never would have dreamed of. So I'm going to give a plug to Mount Sinai because I don't know if they're in the room. Some of their providers in the emergency room using TouchCare at bedside saying, I see you have an iPhone, let me connect you and I'll do a follow-up visit with you in 3 days. Not reimbursable, just to prevent readmissions. Just doing it out of their own sort of practice, and it's just an amazingly powerful thing, a face-to-face call to prevent a readmission 3 days later and say, hey, you go to your primary care doctor, do you follow up with you? Little things like that, and I find the use cases come from the providers, never from us.
Can I jump in? So, Oscar, you've transformed transportation with a convenience service with Uber, and you're poised to do the same with Pager. How do you train, employ drivers versus how you look at that for nurses, nurse practitioners, doctors?
Well, it's to work for Uber, you just need to know how to drive, right? So it's very simple. So that's the only skill you need to have. In healthcare, it's different. So basically, what we're doing is not about training; it's about how can we assure quality along the whole experience, and how can we dispatch the right provider to the right patient. So we're actually we have two areas in the company that are pretty much the cornerstones. One is operations, and the other is product and tech. So we work very closely, to create the whole system as a service. So it's not you cannot divide, the product and tech from the experience you offer, in the house. So we build, instead of Uber, it's a two-sided kind of app. It's supply and demand. You have the driver app, you have the rider app, and you connect them. Pager is a little bit more complex than that because we have the provider app. We also have a command center. We have a dispatch center, and then we have also a patient app. So all these applications are talking to each other just to make sure that the whole experience, is streamlined, is supervised, by a healthcare professional, and deliver, the best service care. So it's not only the onboarding and the training is not only harder, but also the dispatch of the service itself, it's a little bit more complex. And we're adding, just to give an example of the roadmap of the company, what we notice is that when you talk to the nurse, basically 80% of the questions are to gather patient information, and it's a repeatable event. So we're adding artificial intelligence to start, capturing, all this information to free the human, from this interaction, and then just, ping the human when a decision needs to be made. So the decisions are made by humans, but all the information capture is done by a machine. So this is pretty much how complex it is.
Pretty smart.
Thank you. Earlier today, we were talking about the cost of disposable income on average is a couple of dollars a day for seniors.
Yeah.
It sounds like most of these systems are really designed for those of us who actually do have income. What happens with the majority of seniors as they do get older and more of their money is going to pay for general medicine when they need these services? I mean, do you go sponsor advertising supported, sponsor supported? Do you just give it away?
I guess we did. And we didn't talk about pricing, but you can. There's multiple different types of models. So some might say our market segment is that we want a younger patient who is more for convenience, and they're professionals, and they're going to pay $200 for the service to have me come to do something very, very high touch and white glove. Doctor on Demand is a bit different. We try to use the technology to efficiently match the provider to the patient. It's currently a $40 for a visit, so it's not free. We're not in the realm of free yet. In our venture capital, if I said it was going to be free, our venture capital funding would say, "What are you talking about? You can't do that for free." But I think it's 8 cups of coffee to see a board certified physician within 3 minutes is really transformative.
Yeah, I would say this. I think the direct-to-consumer offering has its own pricing, and I think that's an animal. It's going to, of its own, it's going to go up and down depending on market prices. The biggest change has been when the payers and maybe the federal government is coming into this next year. This year is a very important year because the Connect bill, which is a bill that went through Congress, for the first time actually scored telehealth as a favorable intervention, as a money-saving intervention, which opens the door for Medicare to begin to cover it as early as 2017. Medicare has historically only allowed it in very, very funny scenarios where there were things like originating sites. So in order to use telehealth, you actually have to go to a hospital that can then use a device to call to another hospital. It made no sense whatsoever. Yeah. But this is coming next year. Medicaid already has an exemption. Most states in the country now allow Medicaid to sponsor telehealth for people who need it. Yep. And by the way, one of the things that we see, and hopefully this is not plugging a name, but Anthem Blue Cross, who's using our system, actually has a charitable foundation, and they actually took kiosks that use this technology and put it in a community center that had a lot of very, very disadvantaged people there, plugged it into the wall, and there was a line of people who haven't seen physicians for maybe 10 years kind of forming up, and one by one they saw physicians. So the magic of this technology as a way to equate access to healthcare at a significantly lower cost, I would even say that this is going to move the needle on healthcare more than the Affordable Care Act.
But that's moving healthcare into a high-traffic location, really, with the idea it's still going to a physical location to see a doctor whether he's on the screen.
This was just a kiosk. Essentially, anybody can do it if you have an iPhone. It is using the internet for the video component, which is medically required. So you will have to have internet, but that's one of the other things the FCC is trying to do, to proliferate internet access to a lot of people through libraries and so on. So.
Okay, I have a comment and a question. So first I want to give a bit of Swedish perspective. So Swedish system is very different from the US system, obviously, but a lot of the problems are actually the same. The most striking difference, of course, is probably the paying system. So my Parkinson's medication cost $8 a day for me, and I pay $150 a year in total. And equally much for healthcare. So that's sort of the good side of it. One of the bad sides is, though, that there's only very limited reimbursement for virtual visits at all in Sweden. So you guys couldn't make a business in Sweden within the reimbursement system at all.
Unless people wanted to pay for it because they thought it was
There
good
is actually a
value.
startup doing that, and they have people paying $20 for a visit, and they get traffic, so it's moving the needle, definitely. But my question then is about, so in more consumer markets, the customer is always right, but in this case, the customer isn't always right. So how do you deal with the case where the patient are satisfied when they don't get the prescription for antibiotics or similar? If you're working for value and trying to get patient satisfaction.
I think it's expectation management. When you get the pager, the first thing we do is we don't prescribe narcotics. And if you just say that, from the first, just right at the beginning, then the patient is going to be unsatisfied, but it's not going to rant on on Twitter about your service. So it's all about how you manage the patient expectations. It's obviously it's going to be always there's a patient that thinks that he knows what he has and he's just going to tell you what he needs. But we've seen that multiple times. And it's about your internal policies and also how you communicate these policies to your user base. In our case, at least, is this way.
Our time is up. So if anyone has a last comment, final comment.
Oh, I was going to say that I know there's still people who had additional questions. So if you have one for me specifically, I'm happy to be pulled aside in the break if you want.
I would just say the thing to leave with, I go back to Roy's comment earlier, don't think about telemedicine as like low acuity only models for $40. This is about engaging patient providers and care teams with patients in whatever the correct setting and demand point might be. But it's got to be bigger than just, we need to speak to a doctor now because we've got a sore throat, right? It's much bigger opportunity than that.
That's a good note to end on. Thank you so much to the panel.
Thank you.
Incredible insights.
Thank you very much, Christina. Thank you very much to the panel. Just as a reminder, we've heard a lot about policy barriers, including reimbursement. Unless we don't think that policy makes a difference, look at the adoption of electronic medical records for the better or the worse. Think about 30-day readmission. So we have these cards asking you to identify what the top policy recommendation you have for the next president to enable aging at home. We'd love your feedback and thoughts, and we will assemble these into a policy piece to distribute to policymakers. If you fill out your cards and your suggestions, Ryan in the back will be delighted to collect them.